This program is brought to you by Emory University.
Thank you everyone for joining us today. Welcome to the Emory Cardiology Echocardiography Lecture Series. We have Dr. Maan Jokhadar. Dr. Jokhadar is an Associate Professor of Cardiology. He is also the Program Director for Emory Adult Congenital Cardiology Fellowship. He is a fantastic clinician, a fantastic educator, and today he will talk to us about echocardiographic evaluation of diastology. Thank you very much, Dr. Jokhadar.
Thank you for your kind introduction. So today want to give a general framework for understanding diastolic dysfunction, both for clinical practice, but also for the boards. And so we'll start out with an introduction, and then we'll look over the ASC documents and go through the algorithms, not so much for memorization, but more for understanding. That's my goal for today's talk. I have no financial disclosures. Oh, here we go. So let's start out with a question. So about half of all heart failure patients have normal left ventricle ejection fraction. A, that sounds about right. B, that number is too high. C, too low. Or D, don't be silly, heart failure can't be present with a normal ejection fraction. So think about that for a moment. And the correct answer here is that about half of all patients have heart failure with a preserved ejection fraction. In terms of prevalence, HFpEF and HFrEF are about the same. Question 2. Heart failure patients with preserved ejection fraction live longer than heart failure patients with reduced ejection fraction. So who lives longer, HFrEF or HFpEF? Is that statement true, or is it the other way around, or do both groups have similar longevity? Think about that for a second. So it turns out that HFrEF and HFpEF survival is about the same. And that really hasn't changed over the last, couple of decades or so. The difference is in the cause of mortality. So patients with HFpEF, heart failure with preserved ejection fraction, tend to die of their comorbid conditions, diabetes, complications, stroke, coronary disease, etc. Whereas patients who have HFrEF, heart failure with reduced ejection fraction, tend to die of pump failure or arrhythmia. Next question. All patients with systolic dysfunction have diastolic dysfunction. Is that true or false? That is true. All patients with systolic dysfunction have diastolic dysfunction. Very unusual to see normal diastolic parameters that are actually really normal when you look at them carefully in someone with systolic dysfunction. And here the next question is, all patients with diastolic dysfunction have diastolic heart failure. Is that true or false? Turns out only a minority of patients with diastolic dysfunction have diastolic heart failure. Diastolic dysfunction is a echo diagnosis, and diastolic heart failure is a clinical diagnosis with echo help. So the first point I'd like to make from today's talk is that the heart is more than just EF. So let's start looking at some echo pictures here. And we have patient 1 and patient 2. Patient 1 has a small left ventricle that appears to be of normal size really, and a preserved ejection fraction about 60%. But look here, the left atrium is massive. And you have what appears to be a restrictive filling pattern, very tall E and very small negligible A on the mitral inflow. Patient 2, on the other hand, has a large dilated globular heart that is globally hypokinetic. The ejection fraction is 20%, and here we have EA reversal and probably a mild to moderate diastolic dysfunction picture. So looking at this, who do you think is going to be more shorter breath? Or who do you think is going to have higher filling pressures? So the correct answer here, the person who's more shorter breath with higher left atrial pressure, higher filling pressures, is patient 1. Moving on. Which patient has higher pulmonary pressures? Well, let's ask a question. What is the most common cause of pulmonary hypertension? While you're thinking about that, before you answer, what is the most common cause of right heart failure? The most common cause of right heart failure is left heart failure. Well, let's ask the question again. What is the most common cause of elevated pulmonary pressures of pulmonary hypertension? It is left heart failure, whether that's systolic or diastolic dysfunction. When someone has a high left atrial pressure because of systolic or diastolic dysfunction, the high left atrial pressure is going to cause the pressures in the lungs to be elevated. And elevated pulmonary pressures for too long can tire out the right ventricle and cause right ventricle failure. So in this situation, you can predict that this person has a higher left atrial pressure than this person and therefore has higher pulmonary pressures. Next question. Which patient has a worse prognosis? Which patient has a worse prognosis? Is the person with a normal ejection fraction or the person with the low ejection fraction? It turns out that looking at the mitral inflow and grading diastolic function is very powerful prognostic value. And the person with a restrictive filling pattern, even though the ejection fraction is normal, probably has a worse prognosis than the person with a lower ejection fraction and a only mild to moderate diastolic abnormality, lower filling pressures. Another thing to point out here is that left atrial size can be thought of as like the hemoglobin A1C of heart failure. The larger the left atrium, the more poorly controlled the heart failure, whether systolic or diastolic. And that also, and I'll show you some data here in a little while, has prognostic value in terms of heart failure survival. And then here's a bonus question here. What would happen to each patient if they developed atrial fibrillation with rapid ventricular response? So if this person developed atrial fibrillation and they lost their atrial kick, what would happen to them? Whereas what if this patient went into atrial fibrillation and lost atrial kick here? So if this person went into atrial fibrillation and their heart was faster, they'd actually feel more. And in the short term, they'd actually possibly even feel better because the atrial kick, the amount of atrial filling during late diastole is negligible in someone with advanced diastolic dysfunction. Whereas here, in someone with an earlier diastolic dysfunction, grade 1 diastolic dysfunction or relaxation abnormality, if they lose their atrial kick, then that is going to reduce the amount of filling of the left ventricle, and this person is going to get shorter breath pretty quickly and feel worse. So paradoxically, the people who feel worse during atrial fibrillation are the people with mild diastolic dysfunction. And the people who don't feel palpitations or don't feel bad when they're in atrial fibrillation are the people with advanced diastolic dysfunction. My next point is that diastolic dysfunction is bad. So here we alluded to this earlier, and these are data from the New England Journal. These are data from Olmsted County in Rochester, Minnesota, looking at survival of patients with heart failure with reduced ejection fraction and preserved ejection fraction. The red is preserved ejection fraction, and the black is reduced ejection fraction. Here's survival, and here's follow-up over years, these Kaplan-Meier curves. And you can see that the survival is pretty similar between HFpEF and HFrEF. And in that same journal, 2006, that same issue, there was a study out of Toronto looking at survival data. And you can see the similar findings that HFpEF and HFrEF have similar long-term survival. Now, Moeller and colleagues published this study looking at diastolic dysfunction after a MI. So they did echoes after myocardial infarction, and they looked at long-term survival. And here is survival percent, and here is the follow-up in months. The red here is a normal filling pattern, which is a minority of patients. And then impaired relaxation or grade 1 diastolic dysfunction, grade 2 diastolic dysfunction, and here's more advanced diastolic dysfunction. And you can see that the patients who had a normal filling pattern or impaired relaxation, grade 1 diastolic dysfunction, had much better outcomes than people who had a grade 2 or more diastolic dysfunction. And this is regardless of EF and everything else. This is very important, very compelling data. Dr. Redfield and colleagues in Rochester enrolled ambulatory patients who were not symptomatic, who were not recently hospitalized for heart failure, and they looked at their diastolic filling pattern and compared their survival over years. And here's mortality in percent, and here is 5-year follow-up. And here, the solid line here is normal diastolic function. So you can see at 5 years, only a small number of patients died related or died of any cause really here. And then in this line here is mild diastolic dysfunction. So you can see that patients who had mild diastolic dysfunction had 10% mortality at 5-year follow-up, which is very, very important and compelling information. And here you see in this curve here, moderate and severe diastolic dysfunction had even worse survival. Now here you see some number instability because of the lower numbers, but you can see that even though you do have some number instability, the signal is clear that worse diastolic dysfunction is a predictor of worse survival at 5 years. So diastolic dysfunction is a common problem. About the pie is about cut in half between HFpEF and HFrEF. But again, the important point is that diastolic dysfunction and diastolic heart failure are not the same. In fact, diastolic heart failure is only a small proportion of patients who have diastolic dysfunction. All important points to keep in mind. The next point is that the heart is more than a pump. And this is one of my favorite videos I like to show. Here's the pulmonary, and here's the aortic. Here's the right ventricle. And I'd like to point out the crisscross layers of the LV myocardium. See these crisscross layers of the LV myocardium here? And the layers of the LV myocardium. This gives complexity to the way the heart squeezes and relaxes. How the heart winds and unwinds. And in this video here, you see here the heart twisting and untwisting, twisting and untwisting, contracting and relaxing. And both of these twisting and untwisting activities that require energy. It's not just systole that requires energy, but also relaxation or the suction that is created by a normal left ventricle that requires energy as well. So these things are very important to keep in mind. So let's take a look here. no tissue Doppler. Let's take a look at these two patients and try to figure out which patient is normal, which patient is abnormal. So here, both these patients have a normal left ventricle size. This patient has a small normal left atrium. This person has a giant left atrium. So already we're cued in to the fact that this patient is probably abnormal. But I would like to point out something else. And that is, look at how bouncy this heart is. Look at how much up and down the annulus, whether laterally or medially, moves. And you can tell that this heart is normal because it is very bouncy. It's very bouncy. Whereas here, I park my cursor right there at the medial annulus and the lateral annulus, and you see there's not a whole lot of bounce going on with this heart. So this person has pretty advanced diastolic dysfunction, and this person is normal. Now we can measure the amount of bounce that the heart has. And this downward motion we can use as a surrogate for relaxation with tissue Doppler. So by measuring the tissue velocity of the mitral annulus medially and laterally, we can get this tissue Doppler mitral annulus velocity, and the normal numbers vary by age, which is something that is not, in my mind, addressed in the guidelines. We're given simple cutoffs of 7 and 10 for medial and lateral. So the medial is 7 and the lateral is 10 in the guidelines. But really, if you look at a young person, you should probably see numbers close to 20. And as we get a little older, down to the mid and lower teens. So those cutoffs I don't think are universal across the age. If I see a 20-year-old with tissue Dopplers of 7 and 10, that is very abnormal. Whereas if I see an older person with 7 and 10, that's probably closer to the spectrum of normal. But again, this tissue Doppler is the way that we can assess how well the heart relaxes. And that is relaxation, how well the heart is able to suck blood out of the left atrium and pulmonary veins. Let's spend a few moments thinking about the Wiggers diagram and thinking about the cardiac cycle as it applies to the various actions and events that occur throughout the cardiac cycle in systole and in diastole. So to orient ourselves, this here is the aortic waveform. Here's the ventricular waveform. Here's the left atrial waveform. Here are the periods of systole and diastole. Okay, so in systole, you have an isovolemic contraction here, and you have ejection. So those are the 2 periods of systole. And diastole has 4 periods. There's isovolemic relaxation that starts when the aortic valve closes. There's early diastole, and excuse me, early diastole, and notice that the left ventricle creates suction here normally, and this suction creates a filling gradient between the left ventricle and the left atrium, where blood is sucked from the left atrium to the lower pressure left ventricle. And this creates this gradient, gives us the E wave on the mitral inflow Doppler. And then we have a period of diastasis where we don't expect to have any flow. And during diastasis, there's no flow across the mitral valve normally. And then we have atrial contraction. And when the left atrium contracts, it generates another gradient. And this gives us the A wave on the mitral inflow. And then the cycle begins again. Mitral valve closes, isovolemic contraction, ejection, onwards. So it's important to keep in mind the different periods of the cardiac cycle as it applies to systole and diastole. With this in mind, let's think about the progression of diastolic dysfunction. So normally, we have here the blue is the left ventricle pressure tracing during diastole, and here's the red, the left atrial pressure. And notice here that when you have the gradients that give you the E and the A wave. Now notice here with normal diastolic function, you have a supernormal, or you have a normal suction, a normal relaxation, a normal tissue Doppler, like we said, the bounciness of the annulus, and this gives us the E prime. And then we have an A prime that we won't talk about much during this talk. We focus most of our discussion on the E prime and the pattern of the mitral inflow. So here, normally, you have a left ventricle that sucks very well, generates a negative pressure. So to fill the left atrium, we have an E wave, and then an A wave, and a very, very vigorous tissue Doppler. The first thing that happens with diastolic dysfunction is the left ventricle no longer sucks as well, no longer generates that negative pressure as well, and that is reflected by a less vigorous, a less negative E prime. And here we start to see EA reversal. EA reversal. Instead of a normal EA configuration, we see EA reversal as the first sign of early diastolic dysfunction. As things progress and as the left atrial pressure rises, we see what appears to be a normal a normal E to A ratio, but the difference is that the filling pressures are now higher, and our tissue Doppler continues. Notice the E prime getting lower and lower as diastolic function worsens. As left atrial pressure continues to rise, we have even higher left atrial pressure, not much of a negative pressure that is generated by, if you compare here and here, not much of a negative pressure that is generated by left atrial relaxation. Left atrial relaxation is very poor, as reflected by a very small E prime. And then we have an even taller E wave and an E to A ratio of greater than 2, which fits with advanced diastolic dysfunction. Now, what about young, healthy people, young, healthy athletes, pregnant patients? Normally have what appears to be a restrictive filling pattern, an E to A ratio of greater than 2. The difference is that the left ventricle is very good at sucking blood out of the left atrium and pulmonary veins. And so we have a very vigorous E prime, and the left atrial pressure is nice and low. So you can see here the progression of diastolic dysfunction between young, healthy people, normal adults, and then the cascade of progression from stage 1, stage 2, stage 3, and 4 diastolic dysfunction. And notice that one of the more important things we look at is tissue Doppler. And as tissue Doppler worsens, the diastolic parameter changes. Now, let's talk about some helpful tips to try to figure out, for example, normal and pseudonormal. So if I see a normal E to A ratio in a normal heart in a young person, it's probably normal. If on the other hand, I see a normal E to A ratio in someone who has an abnormal heart, whether it's systolic dysfunction, whether it is valvular disease, whether it is left ventricular hypertrophy, a big left atrium, elevated pulmonary pressures, all those are clues that I'm dealing with diastolic dysfunction, and we're talking about a grade 2. Similarly, if I'm confused about which restrictive pattern am I looking at someone with a super normal heart, typically a young person, an athletic person, pregnant patient, without valvular heart disease, excellent tissue Doppler, normal pulmonary pressures. This is very easy to differentiate from someone who has very usually a large left atrium, elevated pulmonary pressures, systolic dysfunction, thickened walls of the ventricle, etc. So those are ways of differentiating the different types of diastolic function, just looking at the mitral inflow and looking at the tissue Doppler. We'll look at the guidelines here in a minute. There are many, many parameters that can be measured, but I think understanding the concepts of what makes diastolic function progress and the mechanisms of it, and thinking through this in a mechanistic perspective helps simplify some of these concepts. Again, like we alluded to, there are clues for when someone's filling pressures are high. So if someone's pulmonary pressures are high, that usually means that diastolic function is abnormal. Now, we're not talking about idiopathic pulmonary hypertension. We're talking about the most common cause of pulmonary hypertension, that is elevated left atrial pressure. And whereas someone with normal or supernormal diastolic function typically have normal pulmonary pressures. Same thing with the left atrium. Left atrium, we said, is the hemoglobin A1C of filling pressures. So in someone usually who's young and healthy will have a normal left atrium, whereas folks who have more advanced diastolic dysfunction will tend to enlarge their left atrium. The caveat to that, the exception to that is pregnancy and athletes. Some athletes, particularly endurance athletes like Tour de France athletes, for example, ultra marathoners can have large left atria. And these large, but the way you differentiate this situation is looking at the tissue Doppler. Tour de France and elite athletes will have super normal tissue Doppler, will have E primes in the 20s plus, whereas people with advanced diastolic dysfunction will have tissue Dopplers in the single digits, 4, 5 centimeters per second type situation. So let's put this into practice. We have 3 patients, patient 1, 2, and 3. And patient 1, 2, and 3, we're going to ask which patient has heart failure. Again, heart failure is a clinical diagnosis. It's not an echo diagnosis, but I think we can make reasonable assumption based on some parameters who is more likely than not to have heart failure. And in this situation, we're talking about heart failure with preserved ejection fraction. So patient 1 has an ejection fraction that is in low end of normal, 50%, but you can see the annulus, see how vigorous that annulus is moving back and forth? See that, how much bounce this heart has? Here you have someone with left ventricular hypertrophy, better ejection fraction, not systolic function, better ejection fraction. Left atrium doesn't appear to be significantly enlarged, at least in the parasternal long axis view. And here's patient number 3, and you can see the very obvious big left atrium. So we're already getting clues about what's going on. And the ejection fraction appears to be normal at about 60%. So going through their Doppler data, patient 1, 2, and 3. Here's the first patient. We said the heart looks pretty bouncy. And sure enough, we have an E prime here of 20 meters per second. And so 20 meters per second, very excellent bounce, very excellent suction. So this left ventricle is very good at sucking blood out of the left atrium and pulmonary veins. And you can see, if you look carefully, see this red here, this single wave going straight from the pulmonary vein to the left ventricle. I think hopefully you can see that over the Zoom recording. And here we have a normal E to A ratio on the mitral inflow. So most of the filling occurs in early diastole as a result of excellent suction, excellent relaxation, and you have a minority of blood filling the left ventricle via the atrial contraction in late diastole. So that's patient one. Patient one appears to be normal as far as we can tell. Patient two, we said there's left ventricular hypertrophy. We have reversal of the E to A ratio, and we have tissue Doppler that is reduced. Here, the tissue Doppler is only 5 meters per second. I'm sorry, 5 centimeters per second. So here's E to A ratio that is reversed. And low tissue Doppler, this is someone who has grade 1, actually grade 2 diastolic dysfunction with the current guidelines, because and we'll go over that in a second, the E to A ratio is more than 14, here it's 16. We would also look at, in the current guidelines, the RV systolic pressure, or the RV systolic velocity. TR velocity, the number to remember is more than 2.8, and the left atrial volume index of more than 34. Those are the numbers to remember in the current algorithm in the guidelines. And here's the last patient, patient 3. Here we have a normal ejection fraction, big left atrium, certainly more than 34 milliliters per meter square, a restrictive filling pattern on mitral inflow, and very poor E prime, only 4 centimeters per second. And with an E to E prime ratio, of 22, very high. So you can guess that patient 3 is the patient who is more likely to have symptomatic heart failure and elevated pulmonary pressures. So heart failure is present when the heart is unable to pump enough blood, keep up with the demands of the body, without increasing filling pressures. And that is left atrial pressure and left ventricular and diastolic pressure. So patients who have HFpEF will often have normal or near normal cardiac output. Sometimes they'll have low cardiac output, but will often have normal cardiac output. But when they exercise, the left atrial pressure goes up, and that's why they become symptomatic. And heart failure can be present even in high cardiac output. Patients who have cirrhosis or AV fistula with dialysis, it's other reasons for high cardiac output failure. Those are patients with a high cardiac output, a cardiac index that is high, but the filling pressures are high and they're symptomatic as a result of this. So heart failure is not just about the cardiac output, but also it's about the filling pressures and pulmonary pressures, etc. A few diastolic pearls to think about. So normal early diastolic filling is due to suction. Again, if things were up to me, I would change relaxation to suction. I think it's a far more illustrative word, a far more meaningful word than relaxation. So normal diastolic function involves a healthy early suction, early relaxation, and early diastole. Late diastole is influenced by left ventricle stiffness, as opposed to or LV compliance. Stretchiness is the opposite of stiffness. So this is a common misconception. So someone who has early diastolic dysfunction is often described as having a stiff heart. That is not true. Someone with early diastolic dysfunction probably has normal left ventricle stretchiness or stiffness, but the relaxation, the way the heart is able to suck blood out of the left atrium, is abnormal. Whereas as diastolic dysfunction progresses beyond stage 2 and 3, that's when the heart becomes stiff. And we'll talk more about that here in a second. The next point is, in the absence of mitral valve disease, left atrial dilation suggests diastolic dysfunction. Again, the caveat is pregnancy and and athletics or competitive athletes. But for the most part, when you see a big left atrium in the absence of significant valvular mitral valve disease, you can usually bet that you're dealing with significant diastolic dysfunction. And the most common cause of pulmonary hypertension, like we discussed earlier, is an increased left atrial pressure, whether from mitral valve disease, systolic, or diastolic dysfunction. We'll talk very briefly about treatment. There's a lot of clinical trials showing very modest, if any, benefit to medical therapy for diastolic dysfunction. There's some various pulmonary vasodilator therapies, but the bottom line is treating hypertension tends to halt the progression of diastolic dysfunction. I actually have several patients in my clinic, young patients, who did have advanced hypertensive heart disease, and over a period of years, the LVH resolved and the diastolic dysfunction improved. So treating hypertension and risk factors is very important. Treating congestion is also important in the treatment of HFpEF. And then atrial fibrillation therapy. And like we alluded to before, it sort of depends on your filling pattern. So if someone has early diastolic dysfunction and they lose their atrial kick, you might be more focused on trying to control their rhythm. But if someone has very advanced diastolic dysfunction and here's their E and they lose their atrial kick, then you might be okay just with rate control and anticoagulation. But looking at how symptomatic someone is with atrial fibrillation can give you clues as to what their diastolic dysfunction is during sinus rhythm, and can also help guide your therapy in terms of how aggressive to be with antiarrhythmics, etc. Diastolic dysfunction can be a clue for coronary disease, and revascularization can be helpful. And then you have to be careful about using nitrates, and that's just sometimes difficult when you have concomitant coronary disease, phosphodiesterase inhibitors, and digoxin for diastolic heart failure. Özlem, are we doing okay with this? Are there any questions coming through? I want to pause before we proceed.
You're doing great. I haven't received any questions so far. We can get them at the end as well.
Okay, good.
You're good to go.
All right, good. So as we sort of build on the information so far, I wanted to try to put it all together as it applies to echo and the cardiac cycle. The beautiful thing about Doppler is that it can be integrated very well with invasive hemodynamics, and also thinking about the cardiac cycle and even physical exam. So I'd like to take this, use this slide to try to illustrate how well things sort of fit together. So if we talk about starting from the top here, and as we move down, here's the myocyte action potential, sarcomere, here's shortening and lengthening, EKG, and then our invasive hemodynamics, here's the aorta, left ventricle, left atrium, and here's our mitral inflow, and here's our pulmonary vein Doppler. So starting from the top, if you take the action potential of a myocyte, okay, and you take many action potentials of billions of heart cells, and you superimpose them and check the signal from the surface, you get the surface electrocardiogram. So here you see phase 0, million phase zeros gives you the QRS. And the duration of the action potential of many cardiac myocytes gives you the QT. And so electrical systole can be defined by the QT interval. That's electrical systole. And it correlates close enough with mechanical systole. And mechanical systole is the S1, S2 duration. So S1, we remember, is closure of the mitral valve, and S2 is closure of the aortic valve. And here we're focusing just on the left side of the heart. We're not going to superimpose the right side of the heart. So first heart sound is closure of the mitral valve. Second heart sound is closure of the aortic valve. Usually, opening of the valves does not generate a sound unless there's an abnormality. So if you hear an opening click, that usually tells you there's something wrong with the aortic valve, such as a bicuspid valve, etc. And here's the opening snap of mitral valve disease early in diastole, shortly after the second heart sound. So a common board question, this is a little bit off topic, but I think it's helpful when you're thinking about these things. A common board question is, how does the severity of mitral stenosis and the location of the opening snap in the cardiac cycle, what is the relationship? In other words, is an opening snap closer to S2 or farther away from S2 tell you the mitral stenosis is more or less severe? And this is something that we're accustomed to memorizing before boards and then forgetting shortly thereafter. Well, let's try to make this memorable. So if someone has severe mitral stenosis, the left atrial pressure is going to be high. And if the left atrial pressure is going to be high, the intersection of left atrial pressure and ventricular pressure is going to occur earlier in the cardiac cycle. In other words, if I have an opening snap that is closer to my S2, that tells me that the left atrial pressure is higher, and it tells me that the mitral stenosis is severe or more severe. So this is just a little side note as it applies to the beauty of the cardiac cycle for physical exam and for Doppler hemodynamics. Now, back here, we're talking about the suction that is generated here in the left atrium. Here's relaxation, and the gradient that is generated here between the left atrium and the left ventricle. And normally you will have a normal E to A ratio, where the E is greater than the A. And normally there's no flow during diastasis here in the middle part of diastole. Now I do want to point out the pulmonary vein waveform. And I would like to point out that the D wave is the exact same intracardiac event as your E wave. So the rapid filling, when the mitral valve is open here, see here's opening snap. When the mitral valve is open and blood rushes from pulmonary vein into left atrium and into left ventricle in one column of blood, that'll give you an E and a D for diastole in your pulmonary vein waveform. And so if you ever see a tall E, you can bet there's going to be a tall D. And conversely, if you see a small E with impaired relaxation, for example, you will see a small D. Okay? I won't spend more time on that. More on the cardiac cycle when it comes to right atrium and left atrial pressure and Doppler interrelationship. So we all remember that the atrial waveform and whether it's left atrium or right atrium is composed of an A, X descent, and then V, and then Y descent. A, X, V, Y. A is atrial filling. V is atrial relaxation, just like the ventricles relax, the atria relax as well. X is atrial filling, and Y is atrial emptying. Y is atrial emptying. And so A, X, V, Y. Okay? And as we time this in the cardiac cycle, A, X, V, Y, we know that Y is with diastole. And Y, your Y descent, is your same as your D. So if you ever have a left atrial pressure tracing and you see steep Y descents, or if you're in the right atrium, you see steep Y descents, you know that you're dealing with probably a restrictive filling pattern and a tall D. You see, if you see a steep Y, you're going to have a tall D. So those are interesting tidbits to help you think through the cardiac cycle as it's interrelated with Doppler. Let me go back to our Wiggers diagram for a moment and point out other helpful things on the physical exam. So notice here that the third heart sound and the fourth heart sound correlate roughly to where the E and the A are. So if someone has a very tall E wave, you're more likely to hear the low pitch of the third heart sound. And if someone has a very tall A wave, you're more likely to hear the low pitch sound with the bell of a fourth heart sound. We remember the progression. Remember the progression of diastolic dysfunction, where you have supernormal, you have normal, you have impaired relaxation, you have pseudonormal, and you have restrictive, right? This explains why we can hear a third heart sound in young athletes, young children, a pregnancy normally, and why if we hear an S3 gallop in a heart failure person, they're more likely to be decompensated. And this also explains when someone has myocardial ischemia, for example, it's a favorite board question, you're more likely to hear a fourth heart sound because of the tall A wave. Now, the pathophysiology of the third and fourth heart sound are related to rapid filling, whether an early diastole, the E wave, or late diastole, the A wave. And it should be noted that these sounds are actually extracardiac in origin. The pathophysiology, the reason for a third heart sound, is actually the cardiac apex, the left ventricle apex, bumping up against the ribs, bumping up against the inner chest wall. And that's the sound that is generated and can usually only be heard with the bell, with very light pressure with the bell at the apex. That's why we only hear third heart sound when someone is lying in the left lateral decubitus. We feel for the apex, we feel the cardiac impulse, we put the bell barely touching that area, and we listen for a third heart sound. That's the correct way of listening for third heart sound and fourth heart sound. Same thing with fourth heart sound, probably an extracardiac sound related to the left ventricle apex being pushed up against the inner chest wall. So if I hear a fourth heart sound, I know what my diastolic filling pattern is. And if I hear a third heart sound, I also know what my diastolic filling pattern is. This is the beauty, the integrative hemodynamics of physical exam, of non-invasive hemodynamics with Doppler, and invasive hemodynamics with heart cath. So, I think we only have a few minutes left. So I won't belabor the point that with normal diastolic function, we have a normal E to A ratio. But I want to point out, here's pulmonary vein Doppler, here's tissue Doppler. I want to point out, again, anytime you see a small E, you see a small D. And anytime you see a tall E, you have a tall D. And you can go through this and process it at your own leisure. I think these slides are being, this talk is being recorded, and you can look over this. And then again, as the filling pressures go up, the left atrial pressure becomes more dilated, the tissue Doppler is reduced, and our pulmonary pressures get higher. This is a nice, helpful diagram to think through as we're troubleshooting diastolic dysfunction. I think in the interest of time, I'd like to just do some take-home points, and then we'll do a quick orientation of the guidelines. So, so again, heart failure is not just EF. Some of you have heard my saying EF SHMEF, which I only half ingest. The diastolic clues, always look at what your RVSP is and what your left atrium is doing when you're trying to assess diastolic function. And the numbers to remember, the TR velocity of 2.8 and a left atrial volume index of 34 or more. And then remember that relaxation really means suction and early diastole, and compliance of the left ventricle is more a reflection of late diastole, and that tells you how stretchy or how stiff the left ventricle is. So let's shift gears here and look at the guidelines, okay? Most of us are familiar with these algorithms for the guidelines. But before we go over these algorithms, I wanted to orient you, particularly as it applies to boards, when you're looking at some of these ASC guidelines. So here's the ASC document from 2016. And then when you're studying for the boards, it's important to look at the diagrams. These diagrams, they love to test these diagrams on the boards, but they also love to test these key points. These are where the questions come from a lot of the time, these key points. So I want you guys, when you look at any ASC document, when you're studying for the echo boards, just download just go to the ASC website, download all the documents. You know, I think it's probably too much to read all of them, but focus on these key points in the ASC documents. These are where the questions come from. Now, to give you some more orientation, if you look at this table, very busy table, looking at the assessment of diastolic dysfunction, the E, the A, all these things, and there are many that are really not as clinically relevant, but it's important to sort of at least have some idea that these are parameters for diastolic function assessment. Now, there we go. Here's some case studies, case examples, and then where is the algorithm? Here we go. So this is the, so if the assessment of diastolic function is different between someone who has a normal ejection fraction and someone who has a low ejection fraction. So let's start out with someone who has a low ejection fraction. So if you have someone with a low ejection fraction, the first thing you do is look at the mitral inflow and look at the E to A ratio. And depending on the E to A ratio, and you use your components of your E to A ratio greater than 14, that's the number to remember, a TR velocity of more than 2.8, and left atrial volume index of greater than 34, you can use this information to assign where you are on the diastolic dysfunction spectrum. It's not going to be normal. It's either going to be grade 1, 2, or 3, and I showed you those patterns. So if you have someone with technical difficulties here. So if you have someone with a normal E to A ratio with a low ejection fraction, it's probably grade 2 diastolic dysfunction. Reverse E to A ratio, it's probably going to be grade 1 diastolic dysfunction. And an E to A ratio greater than 2 is going to be someone with high left atrial pressure. And you can look at this at your leisure. Hopefully the talk that we just gave gives you the foundation to go through this algorithm pretty quickly as you're thinking through it. And then in terms of patients with normal ejection fraction, the mitral inflow and these guidelines are not as important. What's more important is looking at the E to A ratio, the E to E prime ratio more than 14, and you want to look at your septal and lateral E prime numbers. 7 and 10 are the numbers to remember, and these are some of the my humble criticisms of these guidelines, and that is that we're assigning these numbers to all ages, and we just said, that we'd expect, high teens, 20s in a young, healthy person, and numbers closer to this in an older person with medical problems. So again, this I think simplifies it a little bit too much in my view. And then when it comes to TR velocity greater than 2.8 and a big left atrial volume index, and then they use these number of cutoffs. If you have more than 2 out of the 4 or less than 2 out of the 4, then it's intermediate or diastolic dysfunction. I tell you, I take issue with how simplistic this is, but I think it is important to take home that a big left atrium and a higher TR velocity implies higher left atrial pressure in someone with a normal ejection fraction. And also pay attention to the E prime and E to E prime ratio. Now here's a very critical point. And the critical point is you got to make sure that your techs and you are looking at the right thing and measuring the correct thing. Because garbage in, garbage out. If you have data that are not accurate, you're not going to be able to assign the correct information. So check and double check where the cursor is. Are the filters on correctly? Just making sure you're reporting the correct information, because it's important to report the correct information when we're looking at taking care of our patients. And that's really all I had. I wanted to leave a few minutes for questions if we had any, and thanks for inviting me to speak in your conference.
Thank you very much, Juan. That was a wonderful conversation.
Thank you.
I just want to make a quick comment here, Maan. So for the second algorithm that you have shown, if you don't mind just scrolling up a little bit.
Sure.
So mainly for the fellows, so the second algorithm applies to patients with low VF, but also in the guidelines, this has been mentioned that if they also have normal EF with concomitant cardiomyopathy, they have significant LVH, uncontrolled hypertension, significant coronary artery disease, then we're supposed to apply the second algorithm, which is intuitive.
That is correct.
Right. So, the best diastolic function that somebody with low VF or significant LVH or significant uncontrolled hypertension or coronary artery disease is really grade 1 diastolic dysfunction.
Right. Correct. If I see a normal E to A ratio in someone with significant abnormalities on echo, it's going to be grade 2 diastolic dysfunction.
Absolutely.
Absolutely. So if I see a thick heart, big left atrium, elevated pulmonary pressures, and what appears to be normal tissue Dopplers, I'm going to have a hard time believing those tissue Dopplers, and I'm going to take a really good look and measure those correctly.
Absolutely. And I think coming back to your initial point, we can most of the time assess diastology just by looking at the 4-chamber.
Yes.
Right. EF looks normal if the heart isn't too thick, if the atrium is normal size, and if the septum is bouncing, then we're probably dealing with a heart that has normal relaxation and normal diastology.
Correct.
Yeah. Do you guys have any questions?
All right.
Maan, it's Rob Newman. One quick question. I know we've kind of been hemmed in by some of the structured reporting systems. If you had your druthers and you could report diastology however you wanted, how would you design the structured reporting software to, would you stick with grade 1, grade 2, grade 3? Would you stick with normal, abnormal, normal with increased pressure? How would you arrange a reporting if you were able to do it from scratch?
Well, That's a great question. I think a lot of times, this intermediate or indeterminate, I don't like this indeterminate because usually you sort of know around where you are. Maybe you can't assign mild or moderate, but instead of doing that, call it mild to moderate. Or if you're not sure if it's normal, you probably normal or near normal diastolic function. Or, I think, and sometimes I'll say probably normal diastolic function in my comments, or mild to moderate diastolic function, probably advanced diastolic. I think there has to be room for uncertainty and hedging in the reporting. I think simply bailing out and calling it indeterminate, I don't think it does service for our patients. Now, there are situations where you just can't. Where you have mitral stenosis, you just can't. Where you have a transplanted heart, it's very difficult to estimate filling pressures in a transplanted heart. So there are circumstances where I think indeterminate is reasonable. But I think a lot of us, me included, probably use that a little bit more than we should.
The preceding program is copyrighted by Emory University.